So how come when I say that, the state walks away? Okay. All right, so the first thing we're going to do is, I got to go through roll here. So we have a couple of members who are not going to be here today. Dr. Smalling and Dr. Wozniak are not here because of a very celebratory event. Their daughters are graduating from college, and apparently they both have official functions today. So we have good wishes for both of them, but they're still marked absent for the meeting. So Catherine Bissell's here, Craig Cooley's here, Lonnie Dent is here, Todd Haugen is here, I'm here, Karen Pickard is here, David Wampler is here, Neil White? No. And Christine is here, so we have a quorum. And so if it isn't already obvious, I'm sitting in for Dr. Smalling, and we're going to go ahead and just dive into the agenda. Lonnie, are you ready?
Yeah.
So Lonnie Dent is going to give us a report on the current results of the American Heart Association Action Registry. And I don't know where all you live, but where I live, our cardiac care centers and our EMS agencies are very heavily involved working with each other on Action Registry, and we're getting through our RAC, which is giving us great support. And we're learning some really important things about our local system. And so if you're not heavily involved in your communities with the RACs and Action Registry, you might want to think so, because I think Lonnie's going to give us an update so you'll understand why.
So is this on? Can you guys hear me? Okay, great. So what's nice about the timing of this update is that we do have all the results for the nation in from last year for Action Registry. So I'll provide some national data and updates, and then I'll get into some Texas-specific information as well. I have about 20 slides. I really tried to shorten it so that the information I'm providing is meaningful to everyone who's here. So I just kind of picked out some stuff I thought you'd be interested in. So just want to give an overview. Action Registry, get with the guidelines. It's housed at the American College of Cardiology. It's the National Heart Attack Registry, and that's where this data is coming from. This is an updated slide of site distribution around the country. So Texas, this is a little bit behind, 135 it says here. I think we have 138 hospitals in Texas that have contracts. 4 of those are non-PCI capable hospitals, so hospitals without cath labs. The rest have cath labs. And then we have a really, I think, one of the most complete inventories that we've ever had for hospitals with cath labs that are doing PCI 24/7. 154 in the state of Texas, and I mean it might have changed today. It changes all the time as hospitals decide they're going to develop their program and build a cath lab. But right now we have 154. 134 of those PCI capable hospitals have a contract, and then 97 of those hospitals are included in one of the regional reports, like Dr. Peirce talked about, that we look at in the CETRAC region every quarter. So this is just an update on the number of patient charts that have been entered into the registry. And wanted to show you where we are on these metrics. So the first column all the way to the left is door to balloon in less than 90 minutes for non-transfer patients. So this is that, the door to balloon measure that we all talk about for hospitals. We've been trying to meet it for years. We're finally there. 98% of the hospitals are doing that routinely. The second column there is where we've really shifted our focus to those patients who are transfer-in patients. So if they start at the door of an outlying hospital and then they get transferred in for PCI at a hospital with a cath lab, what percentage of the time are we doing that within 90 minutes? And right now we're at, that's kind of hard to read, but it's 32%. And then door to needle, we're still struggling with meeting if the patient isn't going to fall within the 120-minute timeline to make it to PCI in the cath lab. The guidelines recommend lytic administration, and we want that to happen within 30 minutes. Right now, that's only happening 44% of the time nationwide. I'll show you in a second how we're doing here in Texas on those numbers. So this is another way of looking at it, and this is the column on the left is the first door, so the outlying hospital to balloon within 90 minutes that we just looked at, but then also how often are we doing it within 120 minutes, and we're at 64%. Now let's look at Texas. So we're getting from a Mission Lifeline report Texas-specific data and STEMI-specific data. So if you look at that to see how Texas specifically is performing on those measures, it's that middle column there, the state column. We're at 44% and 70%. So if you go back up to this slide, 44% for the pink column and 70% for the green column. So in that way, really amazingly, because of our broad geography, that tells us that there are some really tight processes and coordination going on between EMS and the hospitals and the outlying hospitals and the metro hospitals or the PCI-capable hospitals. So congratulations to all of you. The location of the first evaluation, this tells you where that's happening for both STEMI patients and non-STEMI patients. The pink column is STEMI patients, the green column is non-STEMI patients. And you can see that for the STEMI patients, for both, most of the time that evaluation is happening in the ED. And in Texas, that's happening more frequently than the rest of the nation, that evaluation is happening in the ED, so that stop off in the ED as opposed to fast tracking to the cath lab. So this is, again, state of Texas data. The percentage of the time that the folks are stopping in the emergency room is 78% compared to 19% having their first evaluation in the cath lab. So I know that this is a gap that some of our regions are already looking at and trying to figure out how to address. I know I heard, I've been hearing CATRAC, the Austin region, Mission Lifeline Group is actually working on a fast track protocol so that they can they're trying to identify criteria for the region for those patients who should just go to the cath lab and have their evaluation done there, like which categories of patients would that be appropriate for. And this is median length of stay in the emergency department. So here again, a little bit longer in our state compared to the rest of the nation, about 6 minutes longer. This is really the only outlier on the demographics page. No surprise to anyone here, higher Hispanic ethnicity here in this state compared to the rest of the nation. And I really only pulled out just kind of the outliers, good and bad. The type of reperfusion, this one I circled just because we get asked this a lot. What percentage of the time do our patients get lytics compared to PCI in the cath lab? And it's very comparable with the rest of the nation, as you can see here, 5% versus 6% and 84% versus 82% for PCI. In hospital clinical events, I circled this one because this one's a little bit higher in our state. So these are the rates of when the patient gets to the hospital and they develop problems or issues a little bit more frequently here for whatever reason. We also are dealing with a higher risk population, not such a healthy population in Texas for the most part. So cardiogenic shock is higher, heart failure is higher, hemorrhagic stroke, and how much of this is abstraction issues with data entry and how much of this is real, we're not exactly sure, but it is something that we see on our reports. This is just a quick snapshot. If you look nationwide at heart disease death rate by county, the dark red is, this is just another pool of data from CDC that I pulled in to give us some perspective, and this is death rate by county. The dark red is worse. So blood red is the higher death rates in our country. And if you take a little closer look at Texas, you can see kind of the distribution of the death rates. Again, older data runs up to 2010, so this may have changed. We'll see sometime soon. Statewide, we have multiple regions that are receiving region-specific Mission Lifeline report, so it allows them to benchmark how they're performing. All of the hospitals, even competitive hospitals in a region, all sharing their data so that we can determine, where the gaps are and how we're performing compared to the rest of the state and the rest of the nation. These are the 7 regions that are that have signed consents to receive the reports. We've got, just real quickly, the Border RAC, El Paso region, CAT RAC, Austin region, CB RAC, which is Corpus Christi. They'll receive theirs soon, we're hoping. Their first one, Temple, as well, will be a new one at CT RAC. North Central Texas RAC, they're enlarging theirs. They originally started with the Caruth grant hospitals, and now they've enlarged their, they've broadened their report to include more hospitals. So we'll be adding more hospitals this quarter. CETRAC, the Houston region, is doing this, and then STRAC in San Antonio is doing it as well. One thing that Carla is here from Department of State Health Services. She'll be talking more about Rider 7 in specifics, but one of the things that it has allowed is some funding for more of this data, and they're working out contracts with Duke Clinical Research Institute for creation of a statewide report like this. So the hospitals that are out in some of these RACs where they don't have the ability to do the same type of benchmarking will have that with the creation of this new report. It'll also, Rider 97 also has funding for the state to be able to actually reach in and extract the data that hospitals are already entering to the registry so that we can look at more specifics in relation to the state geography and needs. For those of you that haven't seen a regional report, this is just a sample report. This is actually a hospital report. The hospitals get this STEMI data for their hospital specifically, but also we have now with the regional report the benchmarking. So the hospitals, all the reports to date are blinded. The hospitals are identified by letter only. That's the plan for the statewide report as well. So if you have hospitals reaching out to you asking questions, they're going to receive communication from the state hopefully in the next few weeks to a month, and this is one of the things that the state is asking hospitals to participate in, again, blinded. So their hospital name's not going to be hanging out there, but they'll be able to benchmark. Another page, just another look at that report. And then my last slide is exciting news. Save the dates on your calendar if you're interested in attending the statewide STEMI conference. It's put on by Scott and White Temple, but they're partnering with CETRAC this year in the Houston region. So October 16th and 17th, there will be a workshop the day before, and that's always one of my favorite conferences. And then I think Diana put flyers at the table outside as well if you want to take one of those back to your region.
Is that it? We have questions for Lonnie?
I had one. Lonnie, when you were talking about the door to balloon in one of those first slides, that's actually hospital door to balloon time, correct?
Right. Well, there's one column, and I can give you this slide set if you want to take a closer look. One column is for door to balloon at the PCI-capable hospital, and then there's another column that's door of the first hospital to balloon. So the entire picture of that, the non-PCI hospital transfer time, and then door into the second hospital, and then to device. So we've got that as well.
I was just curious about the EMS component of it.
Yeah,
the first contact. Yeah.
Yeah.
And the other thing I wanted to know was the standard for transfer 120 minutes, like first hospital to second hospital within 120 minutes?
The guideline right now is if the patient walks into an outlying hospital, we want them to be at a PCI-capable hospital, transferred to a PCI-capable hospital, device in, balloon up, vessel reperfused within 120 minutes. If they can't make that that timeline, then we would want the patient to receive lytics at the outlying hospital. So 120 minutes is the cutoff right now.
Okay.
It's a long time, but it's the guideline.
Other questions? Dudley?
Will the statewide report that is going to be paid for and delivered, will it have pre-hospital data in it as far as the breadth of pre-hospital data collected in Action Registry?
Yeah, so great question, Dudley. It will look he's asking about what we're going to have in terms of pre-hospital data in the report. So This is, if the contracts all move through with Duke Clinical Research for creation of this report, there'll be a lot of hospitals in this report. It will look very much like the Mission Lifeline reports that regions are already receiving, so it will pull in those same measures. It's a canned report, so it will have, first medical contact with EMS when EMS is at patient side. I think the ability that we have to get more of that data is going to come from the actual raw data export that the state's going to be able to get if all contracts move through. So that's where we have more of those pre-hospital fields that we can do more with. And they've hired an epidemiologist to be able to work with that data. And so love your input on what you want to see.
Other questions? Okay, thank you, Lonnie. Good job.
You're welcome.
On your agendas, you'll see that the next item is a report on the DSHS Cardiovascular Disease Council interface, which is going to be given by Dr. Wozniak, who's not here. But in his place, Carla Granado from DSHS is going to be standing in and actually reporting on items 2 and 4 on the agenda. So she's also going to report on the Regional Advisory Council ST Elevation Myocardial Infarction Survey. Ms. Granado, thank you. Thank you so much for standing in. And we recognize that, by the way, Ms. Granado is a new employee of the state and has been on the job, 2 weeks, you said?
About a month.
About a month.
Yeah.
And so here she is in the batter's box after only a month with the state, and I think that is something we really appreciate. So congratulations. Welcome to Texas.
Thank you.
And now impress the heck out of us.
I'm going to have to take this off. It's too short. Okay, so as far as the Texas Council on Cardiovascular Disease and Stroke, just an update. We had a meeting on May 2nd. Some of the presentations that happened were with Dr. James Woodson with Pulsera. They presented on an application technology for stroke and STEMI data collection. Shilpa Shamapant from Austin Speech Labs. She presented recent data findings from their program, which does intensive speech, language, and cognitive therapy for stroke survivors. And one of the last presentations was from one of the staff from the Office of Surveillance, Evaluation, and Research from DSHS, Veronica Pedron. She presented a report on the state of CVD and stroke in Texas with a particular focus on health disparities. And I also provided an update on Rider 97, and I'll go ahead and go into a little bit more detail about that project. Right now, the Department of State Health Services is working to execute several contracts. We're going to obtain hospital and regional data for stroke and STEMI systems of care. We're nearing the final stages of contract execution with most of these contracts and most of these vendors. We're working with the American College of Cardiology Foundation, and that's to receive raw data from hospitals that are registered with Get With the Guidelines Action Registry. That houses the STEMI data. We're also working with Duke Clinical Research Institute, as Lonnie mentioned, to obtain a statewide Mission Lifeline report that covers some pre-hospital data. On the stroke side, just very quickly, we're working with Outcome Sciences, a Quintiles company, to receive super user access to Get With the Guidelines stroke hospital data. And the last contract will be with the individual regional advisory councils to receive pre-hospital and hospital data. And it's also going to include a STEMI survey that Dr. Wozniak was going to update on. That's actually going to be mailed out to the RACs probably in the next week or so. In terms of next steps, again, we're working to finalize these contracts to be able to obtain that data. We're working with our contract management unit and legal to finalize data use agreements between DSHS and each hospital, and so we'll be sending out hospital communication packets to individual hospitals, and includes information about registering and Mission Lifeline and Get With the Guidelines, as well as obtaining their approval to get their data through these vendors, through data use agreements. And so next week, we're actually going to host a webinar with the RACs to discuss the deliverables.
Great.
That's it.
Questions? Lonnie, anything to add?
Great update.
Great job. Okay, thank you.
Thank you.
The next thing, Catherine, you're going to talk to us a little bit about the GETAC web portal for development for the GETAC Cardiac Care Committee, for our committee.
Yes, since the
Hang on,
last
hang on.
since the last GTAC meeting, we've had 2 articles that have been submitted, and they have gone to the review group, and we have not received consensus on that yet, so they have not been posted. Dr. Cooley has also scripted a disclaimer that we're going to add to the website. The disclaimer simply says, in a nutshell, that we don't endorse any of the articles on here. They're provided for your resource and for research value, and that's pretty much all I have. Any questions?
All right, we're going through the agenda. Charlie, too fast. You have to talk more. All right, we actually are going through the agenda really quick. We're down to our last, second to last issue. The Stop STEMI iPhone application. Christine, you have actually a pretty interesting update for us, I believe.
Yeah, I actually asked the representative to come give us a real update from the company itself. This is a pretty cool software application, and in the places where I have seen it implemented and being utilized, this application is saving 20 to 30 minutes off of our total ischemic times in these areas. It starts with EMS, it ends at the receiving PPCI center. There's also now a stop stroke application, and it has some statewide potential, I think, in it. And so I've invited Shane Elmore, who is, and you may have to repeat your credentials, Shane. Shane has been in this industry a long time, and so he is, the company that produces this is called Pulsera, and quite a few, I believe, of our racks have looked at this product. It's a pretty awesome product. So I'm going to turn it over to Shane, and anything I missed, Shane, you fill in for me. It might take him just a minute to get it set up.
Yeah, he's
Okay, if I receive any inappropriate text during this, I apologize. Not just thank you so much for the introduction. My name is Shane Elmore, as she was saying, and I'll tell you a little bit about myself. First of all, started off in ICU. I'm an RN. I started off in ICU, went to the emergency department, and then began to work in EMS, working actually for Airbag, flying all over the state for the most part, and went back to Mother Frances Health System and worked there for 3 years as the STEMI coordinator and EMS liaison. And one of the challenges that I regularly ran into was our STEMI and stroke process. It was a very cumbersome process. Actually, we did a great job of achieving the goals and the benchmarks, like we said, at 98% or whatever that is. But I was always frustrated.
Is he going to be picked up by the mic? Is that acceptable?
No.
No. Yeah, you need to actually use the mic, otherwise the people watching on the web can't hear you.
Can I pick it up?
Yeah, if you want to grab that one there,
Okay.
that might be better.
This one wasn't.
Yeah. You can actually walk around with that one.
Okay, how's that? But it was a very cumbersome process, and it was challenging. So we were doing a great job of reaching the benchmarks. But the challenge is all the work it took to make that happen. It was keeping so many different balls in the air that inevitably one of those balls would fall. And we always knew where we were vulnerable. It was always in the area of communication. And so I was looking for an application on the iTunes store and things like that for a couple of years. And then one day a medic comes in from a competitor hospital. This technology was actually started there in Rack G at the Good Shepherd Health System. And he comes in and his eyes were really, really big. He was engaged. And he was showing me a 17-minute time for a door-to-balloon. And I thought to myself, we've had outliers like that. It's just a fluke thing. And then another medic comes in really, really excited. His eyes are about this big around. He's talking about a 24-minute time. But then it began to dawn on me that they're taking patients to another hospital that they used to really enjoy bringing to my hospital. They're getting feedback instantaneously that takes me a month to get out to them. And I began to ask myself the question, how can we get medics engaged like that whenever they're bringing STEMI and stroke patients to our hospitals? And so I set up a conversation, a meeting with Dr. James Woodson, who is the creator of this technology. And honestly, I was going over there to shoot holes in the product, thinking there's no way that a technology like this could exist even though I've been looking for it for a couple of years. And so whenever I finally had that meeting, I couldn't shoot holes in it. No matter how hard I tried, it was clear that this was a technology that was created by clinicians for clinicians. So unlike you see in the EMR world where we took a paper chart and made it electronic, we actually have taken this and redesigned it from the ground up with the way that communication is supposed to work. So that's how I was introduced to this company, and the results that we are getting is amazing. So Pulsera is a acute care coordination company. Okay, our product, anytime you think about acute care coordination, anytime you have multiple resources that are scattered throughout a facility or a region, you have multiple facilities, multiple people, we're going to coordinate those people around time-dependent diagnosis. And so we have been up and live running with Stop STEMI and Stop Stroke for over a year. And soon to come, you will see Stop Sepsis, Stop Trauma, and then a general alert app that will actually remove the radio report calls for EMS when the inbound traffic coming to the emergency department. And so I'm excited about the opportunity to give you a demo here today. And you know, we're so new and out there with the technology, it's really challenging to find a system that will display multiple iPads at the same time. So let me. Okay, here we go. So what we're utilizing is mobile technology. So this is just an iPhone. It works on any Android or iOS device. Whenever a medic is on scene, or maybe it's an EMT basic that's on scene because you don't have a medic in your area, they're going to log into the application, and they're going to select new. Can you see this okay up there? They're going to select their hospital. When they do that, it will auto-calculate the distance in the ETA to the hospital based off of the GPS coordinates in the device. One of the things we needed to do is engage everyone along the way. The question is, will EMS use this? We're going to use this because it makes their job easier and makes their job simpler. Very seldom do we ever provide a solution that actually makes your job easier. So medics are really enjoying using this, and as a matter of fact, they're our #1 referral source right now. And so this is going to take them 30 seconds tops to fill out. But you'll notice here you have your at-patient and scene departure time. This is the metric that they're shooting for. And so this is going to go into a Hall of Fame. So it's going to be reported with them and their partners. So they'll select their at-patient and their scene departure times for their metric. And again, you can see that you have the ETA. They're going to put in a first and last name of the patient. Then you have age, gender, height, and weight. One of the things that we really stress is that if you're pushing a button on our application, there's a reason you're pushing that button. One thing you'll see throughout the demonstration is that everything that's pushed and every data point, everything that's captured becomes a data point. So we passively collect all of the data that you need in real time for STEMI and stroke, sepsis, and trauma. So as you interact with the application, you're automatically collecting the data. But we're not primarily a data company. We're not primarily a company that just gets an ECG to the hospital. And so you kind of have to break out of that mold of what does this platform do and what does it look like. And so there's some data points that we don't capture because if you push a button, it means something. The reason we include the height and weight is because the cath lab needs this information just to power up the equipment and get that going. And so what we'll do next is you just hit the View Add EKG button, and actually the projector thing messes up whenever we do that. But in real life, you're just going to view EKG, and you're going to take a picture. Well, we all know that the diagnostic quality of this is more than adequate because we do that now, don't we? We take a picture of the ECG and we send it to the doctor. The problem is, whenever you do that now with your existing technology, is you have personal information that's stored on your device. Well, this is like a HIPAA-compliant Instagram. Nothing is saved on the device. And so whenever you take a picture, it's saved in the cloud. So if I go back into my phone and look at my pictures, you're not going to find any information on the patient in there. So it's completely secure. And then you're going to hit New. Up so you can hear it. Oh, it showed up. Awesome. Okay, so now you heard the alarm going off. This is what you're going to hear in the emergency department. We call this role a charge nurse role, but it's important to understand that of all the systems we're implementing in and talking to, we've not found one system yet where this doesn't work. Okay, so we're not here to change your existing successful program. What we're here to do is help improve the speed and efficiency of that protocol that you've already set up. So picture this more as a communication protocol, not trying to change the protocol that already exists. And so in the emergency department, you're going to hear this alarm, and the alarm goes off. Everyone in the room knows what's coming. Well, everyone in your department knows exactly what patient is coming in without a word being spoken. You kind of have a Pavlovian response. And so they're going to hit new, and they're going to have the first and last name, age, and gender of the patient. And then you're going to work this top to bottom. Some of the things that you will see, first of all, you're going to see a phone icon here. The phone icon, all you have to do is hit that button. If this were actually a phone, it would launch the phone application and actually call the medic in the field. Well, some of you say, listen, I don't want the ED to be able to call my medics in the field. Well, it's real simple. You just don't put a number in there if that's what you don't want to happen. So you're able, anywhere you see a phone icon in this application, you're connected to that team member. Cardiologist, ED physician, departments, everyone is connected together. All you have to do is hit view or add ECG, so I can look at the ECG and I can go down to the bottom here and cancel it right now if it's not a STEMI. If it is, I can go into the record and add another ECG so that the cardiologist who's on their way in can take a look at an old ECG and the new one at the same time. So we looked at our ECG. Now, one thing, the EMS has no way of knowing in your typical system who's on call for STEMI or stroke. And so that's why we bring a funnel that's going to one person that's responsible for EMS traffic in the emergency department. They're going to look at their call schedule, however they do that now, and they're going to select their cardiologist that's on call. They'll also select an emergency physician that's on call, and then they'll hit activate. Now, I signed in very few, and these are not going to be projected, but one of the things that you're going to see whenever this comes across, it's going to be the same screen that you see right here. So walking through this, let me cancel that. So walking through this demo here, what you're able to see are some very, very basic things here. Working top to bottom, so we're all on the same page. EMS has this same screen. The emergency department has this same screen. The cardiologist, the cath lab, everyone who's logged into the system has this screen. One of the challenges that I experienced in the emergency department was you activate a STEMI, but you have no way of knowing if the team is actually on their way. You don't know until 15 minutes later, because what happens is they're going to call an operator. The operator's then going to send out a page. You're going to have a page going out to 4 different people. Those people are going to be calling back confirming that they got the page, but the end result, the person in the emergency department needs to know that the team has been activated and that they are on their way. You can look at the View Alerts button here, and every single person on this page, if you see a green check mark by their name, that means that I've opened the application and acknowledged it. If you do not see a green check mark up there, that means that I've not received it. All you have to do is hit a phone icon over to the right, and you're immediately connected with that person. There's no way of doing this now with a pager of knowing if they've received that alert or not. You'll notice on the very front screen here, you also have the ability to view the ECG. You have your emergency department and your cardiologist on the very front screen, and you'll notice a green check mark by the cardiologist's name. That green check mark indicates that without a phone call, the cardiologist has already received this case. And so there's no use in placing a phone call to that physician. It instantaneously happens. One of the things that happened in my system, I'm sure it happens in your system, is we think that Dr. Smith is on call. And after about the 3rd or 4th page, if Dr. Smith is very courteous, he'll give us a call back to say, I have no idea why you're calling me at 3 o'clock in the morning because I'm not the cardiologist on call. It's a very simple process. As you go in here and you can change it with the click of a button, and you've changed the cardiologist. It will remove the one that's not on call, alert the new one, and the entire team will know without a phone call that the cardiologist has been changed. Once the patient arrives in the emergency department, they're going to hit door time. Okay, I'll back it up a minute here, and they'll hit door time. And then we get alerts that the patient's arrived. So the cardiologist who's on their way in, maybe they're on another floor, the cath lab, everyone knows that the patient has now arrived in the emergency department. One of the things that you'll see are bar timers. The green is the facility average, and the red is the current patient. So looking at that bar timer, it's a real quick way of looking to see, are we behind where we should be at this phase in the game. Again, we've engaged EMS because they have their scene times. We're removing that radio report so it makes their job easier. Well, we've clearly defined what needs to happen next. For the emergency department, it's door in, door out. How quick can we move this patient through our system? And so this is the metric that they're shooting for, and that's what this bar timer for the emergency department is representing. It represents the job that we're asking them to do within our system to help facilitate getting this patient to the cath lab as soon as possible. So again, green is facility average, red is the current patient. When the cath lab is there and ready, they will toggle the cath lab ready button, which will send out an alert to everyone saying that the cath lab is now ready to receive the patient. I can't tell you, with the Society of Cardiovascular Patient Care, I've been on the receiving end of hundreds of emails where people are asking the question, how do we develop a bypass protocol to allow a patient presenting by EMS to go straight to the cath lab? It's really simple with this. If the patient's not there and the cath lab toggles that they're ready, why stop in the ED? The cath lab's ready, so you keep going. If they have not toggled that they're ready, they simply stop in the emergency department and do everything that they need to do until the cath lab is ready. We were able to shave in the beta testing 67 minutes off of STEMI transfer times by utilizing this platform alone. And so you can expand the transfer feature here. I can select a facility. I can select the cardiologist. This will alert them. Their phone will go off. They can approve the transfer. They can see the ECG, and they can activate their cath lab team all without a phone call. So that's how we were able to shave 67 minutes off. Here you will see the big timer starting with the EMS time to the left and going over to all the way up to your 90-minute goal and your 60-minute stretch goal. Probably the most impressive piece of this is a real-time first medical contact timer and door timer. So in real time, we're the only ones who's able to provide this right now, is in real time, you know what your first medical contact time is. Whenever we come into a facility, a lot of people think, well, you really focus on times too much. We focus on the patient. Well, what we realize is that people have never known what the times were in real time, and so we've learned to ignore those times. When people have a clock and they can see an ECG, it creates a sense of urgency that no one else is really able to duplicate. And then, of course, you have your door timer. But when it comes time to stop the case, you'll hit Stop STEMI. There's 3 different ways you can do it. You can say thrombolytics are given with a time. You can say device across the lesion with a time, or you can cancel STEMI. And whenever you cancel it, this is a customizable list. And so maybe this was an early repolarization, and it was an inaccurate diagnosis of STEMI, or maybe it was a left bundle branch block. Maybe the patient went for primary surgery. Whenever we cancel it, we put the reason in, and then we confirm the stop. This alert goes out to everyone on the team, letting them know what's happened with the patient. So that loop closure that we've all been challenged to provide, that creates so much work to put together, has now happened instantaneously for EMS. So they're on their next run, their phone goes off, and they're able to look through and see exactly what happened with the patient that just 10, 15, 20 minutes before they had taken to the cath lab. So the way we are all about uniting an entire region, and so I'm here today to present at an invitation, and I say thank you for that. And maybe it is something that at the state level you want to look at and say, what does this look like to have real-time information available and at our fingertips? What does it look like to have a STEMI and stroke system where if we put a helicopter in an area, we see the times go down and can really correlate that? Or you have education done on calling 911, and you can see real time in the area that more people are actually presenting by EMS instead of walk-ins to your regional facilities. I mean, the sky's the limit here, but the STRAC is of one RAC that we've been working with and are proceeding forward with. There are other RACs that have a lot of systems already in place, and maybe you don't see this as a fit for you, but we would challenge you to say, well, we know that we have found a great solution here, and we'd like to make that available to you. But if you know of hospitals in your area that are struggling, meeting all of these times, this is a very simple system to implement. And we've, within 3 months, we're showing amazing results with this system, and they've maintained that for over a year. And so I will be available in the back. I'm available for questions. Would be happy to show you a stroke demo as well, and answer any questions that you have. Thank you.
Do we have time for some questions for Shane?
Yeah, we got plenty of time. I got a question.
Okay.
So a couple of things. One is, so I get how this is all real time, but let's say I'm the person who abstracts data later on.
Okay.
And I got forms I got to fill out or whatever. How do I get to this? Is there a way for me to go in and look at the case that occurred yesterday afternoon, right after I left the office?
Exactly. So, first of all, like coordinators can actually be logged in at home and watch the case unfold. Whenever we were in San Diego at the Society of Cardiovascular Patient Care, it was really a drawing factor that there were people there watching the case unfold on an app. But as a QI person or some type of a quality role, there's a dashboard, an administrative role. There's a dashboard that you have access to that you can log in to that dashboard at any time. It's a web application, and all of these times are available. Even down to who pushed what button is all available if you want that information. And so you can log in anytime. You can actually export that out into an Excel or a PDF.
Mm-hmm. So, and then the other thing, and I may have misunderstood you in the beginning, so I'm the medic in the field, and I'm using my phone on this, and I take the photograph of the 12 lead and I send it. You said that doesn't get stored in my photos, that so it's HIPAA compliant, that's not in my, well, the rest of the data, does that also go off my phone? It's when the case is over, or do I wind up having all these cases on my phone?
You will not have the cases on your phone, but it's up to the health system as to how long you want that information to be stored on the phone. For example, you may want to leave it on there for an hour just in case they forgot to hit a time or they forgot to do that. They can go back and add that time in. Now, it will indicate that the time was added in later and who added it. So you have that a way of knowing when the data was entered in. But that's a setting that the hospital, most people are setting it 1 to 2 hours, that it'll be available on their phone before it's turned off.
Okay, and then one last question. So you show this as an iPhone application. Is this iPhone specific, or are there other?
Any Android or iOS device. So it'll work on an iPod Touch, iPhone. I say we do smartphones, and Androids. So. Okay.
Sorry about the BlackBerry.
Good question.
My question is, how are you synchronizing your times? How are you
What's that?
synchronizing times between devices?
Well, that's the thing. Our time is using the universal timer at the bottom, and so that's one of the way that we keep everyone on track. It's important that when we look at documentation, one of the number one questions is, does this slave over or integrate into the EMR? And the question is no. This is a communication tool, not a documentation tool. So you will find that we are documenting times off of our universal clock that is going into the medical record. So EMS is now synchronized with all of the health systems, the cath lab with the ED, the cardiologist, and everyone, instead of using individual watches and things like that.
Lonnie, I think you had a question.
Yeah, so this is related to Dr. Purse's question in documentation. So hospitals, for hospital accreditation, have to report the times that their team was notified, the cardiologist was notified, but also when they're arriving at the center. So you may have said this and I missed it, but are those captured as well, the notification times and the arrival times?
Well, one of the things that we didn't do, and this kind of goes back to the statement that I made, that we are not a data company primarily. We passively collect what data that we can. And so we do not capture that piece of information to say that the physician has arrived. It's important for data purposes and reporting purposes, but as far as moving the system along, it becomes really clear to see when that patient arrived. One of the things that you're able to look at in our next rollout is we have a template communication piece to where there's 8 different pre-designated things that you communicate around so whatever you want that to be, stop in the cath lab, go to ED, repeat 12 lead, physicians arrived, or cardiologist in cath lab. You can put whatever you want. There's a ninth free text area. So if you want to build that into your system, all you have to do is build that into that template communication. When the physician gets there, you hit a button, and everyone knows that the physician has arrived. So, good question.
Other questions?
I'm just going to quickly say I just double-checked out this STRAC out of San Antonio. We are going to kind of look at this over the next several months at a regional level and kind of see how things go with the cardiac and stroke application. So it's exciting. And one of the things I think when we were having the discussions at a regional level, certainly different hospitals have different mechanisms on how they do their paging system. And this overlays pretty well, I think, on most of those systems, even where I'm at is a big academic center, and going through some of the nuances of paging multiple cardiologists and these kind of things still will work. So I think it's something to certainly, we're excited about it. We'll see where it goes.
Yeah. We also are going to look at it at ARIVAC Life Team and allowing all of our bases. If this trial goes really well, we're starting in North Texas and allowing all of our crew members to utilize the app. One of the cool things that I thought about this, that I just got excited, was that as an administrator, I'm struggling with getting EMS, First Medical Contact to device times to do my recognition award, and I could actually get these times directly off of the app, so that would certainly make mine 3,000 entries life easier. I think we have some more questions from the audience.
Okay, please come up. She needs the microphone.
You need the mic.
With all due respect, it sounds like a wonderful product, but if we're going to look at specific products, I think we need to hold a vendor fair outside of the meeting so that all of the vendors have an opportunity to present their products.
Absolutely, and I'm not aware of another product right now.
I'm not either, but I didn't ask anybody, so.
Yeah, well, I did, but absolutely.
I think her point is this isn't a vendor forum.
Point taken. All right. All right, so we're going to move on to the next and final agenda item, and this is, what I'm about to discuss, we've discussed at the EMS committee and the EMS medical directors committee, and this is really just an awareness and possible action item. So everyone should have gotten the pre-reads, which consisted of two. One was a research article which was recently published in Resuscitation, and also a scientific statement from the American Heart Association. And what it concerns is a conundrum which has sort of developed with resuscitated patients who've been resuscitated from cardiac arrest, who are brought to hospitals capable of doing cardiac catheterization. And what the research has been showing is that these patients who've been resuscitated, certainly those that appear to be having STEMIs on their post-resuscitation 12-lead ECG, the assumption is that they're having an acute STEMI, and that's what precipitated the cardiac arrest. And in many cases, in the vast majority of cases, when those patients are taken to the cath lab, they are in fact found to have a correctable lesion. What was not anticipated is that many patients who do not show STEMI, who are being taken to the cath lab, that a very large percentage of those also have correctable lesions, even though they weren't showing STEMI on their 12-lead. And in the most recent article, and there's several articles that sort of address this, in the most recent article looked at patients who, specifically looked at comatose patients after cardiac arrest who did not show a STEMI, and they were taken to the cath lab. And as I said, many of them had correctable lesions, but also those that were taken to the cath lab had better mortality statistics than those that didn't. And so if you consider the spectrum of patients, and the way I've described this in two previous, is that if you have a healthy patient, and I use the example of a 45-year-old runner who's out running with his cath lab team buddies, and emergency department nurses and physicians and EMTs and paramedics who all hang out together. And they're jogging one sunny day, and he collapses in cardiac arrest. He would probably get immediate bystander CPR. And of course, one of the paramedics would have their own personal AED available, and the patient would get shocked promptly. And by the time EMS arrived, he may even be able to demonstrate some neurologic function and get to the emergency department, where he would likely be hemodynamically stable. And the 12-lead, should it show a STEMI, that patient would almost certainly go to the cath lab. Agreed? And we would all expect that patient would have a high percentage likelihood of a good outcome, right? Okay, so now you compare that person from this end of the spectrum to the elder patient in a nursing home who has chronic illness and has an unwitnessed cardiac arrest. The initial rhythm is asystole, does in fact get resuscitated in spite of the fact that there is no bystander CPR, and is brought to the hospital in cardiogenic shock with a ECG that does not show a STEMI. So what is the likelihood of that patient going to the cardiac cath lab? You got a lot of comorbidities, the patient's in shock, they don't have a STEMI on their ECG, so why would you send them to the cath lab? And the reality is that most patients fall somewhere in between these polar descriptors that I've just given. And what the research is showing, and there are multiple articles of research looking at these patients in between from different angles, and what it's basically, the long story short is that patients that are taken to the cath lab after having been resuscitated, first of all, patients are doing better than was probably predicted, and patients with certain risk factors those risk factors are not panning out as being as predictive as we would have thought. And so that being said, At the same time, the payers, those being CMS as well as the private insurance payers, have linked your payment, you being either the institution or the operator, the physician, have linked your payment to your statistics in terms of morbidity and mortality complications of the patients you bring to the cath lab. In other words, that was designed to encourage you to be a technically more proficient care provider or care system, and do everything you could in terms of looking at your times and making sure everybody's educated, that you've got the latest equipment, and you use the best techniques, and so on and so forth, so that your patients would have the best chance, and therefore that would be reflected in your statistics. But what was probably not considered as they put those metrics together was the variability that comes into that when you include high-risk versus low-risk patients. And so hospitals now find themselves with the patient, let's say I describe these two extremes. Let's look at a patient somewhere in the middle. Let's say it's a young 45-year-old person with no past medical history who had a witnessed cardiac arrest, got immediate bystander CPR. We'll even say the AED was applied. It did not advise a shock, so the patient was in a non-shockable rhythm, gets resuscitated, goes to the hospital, and is profoundly hypotensive in cardiogenic shock, but is also showing a STEMI on their 12-lead. So if you're the cardiologist, they got a STEMI, so you need to be thinking about going to the cath lab, but with pressors, they're barely able to maintain a pressure of 80. They've got rails. That's a high-risk patient. There's a good chance we're not going to have a good outcome here. And if we don't have a good outcome, my statistics are going to go down, and not only will my reimbursement suffer, but so will that of the institution. And so there is a real moral dilemma that is created by this method of determining how people are going to get paid and how much. Certainly, it was unintended, but nevertheless, it is a fact of life. And so the American Heart Association published in Circulation a scientific statement that is a great compendium of all of the research that I was talking about that demonstrates these patients do better than was anticipated, or what we would think would be anticipated, and also the dilemma and the moral ethical dilemma that it puts caregivers in. And I will tell you that in my community, I have anecdotal evidence and conversation that I have some institutions which are saying, kind of damn the torpedoes, we're going to take everyone to the cath lab. And we've got other facilities that are extremely anxious about who they take to the cath lab because and there are pressures on the cardiologist. Sometimes the cardiologist is the one's worried about the numbers. Sometimes the institution's worried and they're pressuring the cardiologist and vice versa. And it's a problem. But the scientific statement from Circulation is really very complete, and I would encourage you, if you haven't already read it, to read it again. And so the potential action item from this committee, we said the same thing to the EMS committee and the EMS medical directors, is, can GETAC, should GETAC, is it within our purview to make comment on this somehow? And basically, I would recommend that we reinforce the position of the American Heart Association that this is a problem. So two things. One is, if you weren't aware of this conundrum and this potential conflict of interest, you need to go back home into your community and see what's going on in your community. That's number one. And number two is there anything that we can do? So I offer that up for conversation. Of course, our two interventional cardiologists are not here.
I do have one question. I've always been a little confused, and I think I understand, but the data we're talking about is the CMS data specific to the procedure in the lab, not necessarily related to like STEMIs or the heart alerts that they turn in for example, get with the guidelines, right?
Yeah.
When I sit on my internal hospital cardiac committee, those seem to fall out of certain reporting things, but I'm assuming they're getting, my cardiologists are still very cognizant and concerned about the data. So this is a CMS
This is right.
issue, right?
It's the CMS situation that sort of drives the reimbursement conflict. Yeah.
But those are becoming more closely aligned. So I think the big thing that came out of the National Heart Attack Registry Conference this year is that CMS is working closely with the national registries, and they're looking at trying to match definitions and also actually using that data instead of having hospitals report to CMS and then have them report to the national registries as well. So that hasn't happened yet, but just they're becoming they're coming closer.
Well, one thing in here that I should point out is the final part of this is that they make the recommendation that for patients who've been resuscitated from cardiac arrest, they not be included in those statistics, in the calculation of morbidity and mortality, that these patients, that you can do that with your routine caths, your diagnostic caths, your therapeutic caths. You're not, even an emergent cath, as long as it's not in a patient resuscitated from cardiac arrest. It's sort of the recommendation on the last page in here.
So I had two questions. So when you say those data sets are merging, is at this point, does it look like the registries are going to absorb the CMS definitions so that it would be, they would currently include the post-arrest patient in a sort of a negative light?
Yeah, I don't know what's going to happen to the arrest patients, but what I'm hearing is kind of the opposite, that CMS would be adopting the registry definition. So instead of them coming up with the data the measures and the definitions, that they would be adopting those that are being used by the national registries, not just cardiac,
right.
but all of them.
I think medical directors kind of hit it on the nail on the head earlier when you were presenting to them, and I'm not sure what we do with it after we come up with it, but I really think that this committee, them, and EMS should get together, and as 3 committees together, come up with a position statement or a paper. Where it goes, I don't know the answer to that either. But as they mentioned, I think this is going to have far-reaching effects, not just on cardiac. And I think they had some really good ideas, and I think between the 3 committees, we could come up with a very powerful position statement if we all pooled our resources together. That would be my suggestion.
Yeah, I agree. I think that is what the EMS medical director said.
I would just say, I think one caution would be, I don't think we want to necessarily throw out that data, but we want to carve out that data. I think it's important data to know what happens to the post-arrest patient and having it included in the registries, but not make it a punitive report, or not make it where it's where the public can look it up online per se. But I think it's important to have the data available, but just not make it, a punitive issue.
Good point. Good suggestion.
So just to add into this conversation as well, as you move closer to the bleeding edge of this topic, and that's taking the patients who are still in arrest to the cath lab. So they're in a persistent VFib, but it's your same 45-year-old runner who has optimal care prior to the cath lab, but get them into the cath lab even if you have not restored circulation.
Right. And in my community, I have one hospital that does that, and I have many hospitals that don't.
Well, it's treacherous because these are truly heroic efforts that they get penalized for, and that's the issue.
Right. Other comments in the committee? Okay, so Todd, you came up with a good suggestion. Do you want to convert that into the form of a motion?
Yeah, so I would make a motion that this committee team up with the medical directors committee as well as the EMS committee and come up with a position statement on this topic and what we feel needs to be addressed from the standpoint of, like Dr. Cooley was saying, that the data still needs to be there, but so that it's not a punitive thing against facilities or physicians. Because eventually it's going to reach even down to EMS, I can see.
We have a motion? We have a second? Discussion? All in favor? Any opposed? Motion carries. Okay, so that's what we'll do. That brings us to the end of the stated agenda. I don't have any announcements. Is there anything from anyone in the committee they want to bring up? And what I don't see on here, but what we usually have is the opportunity for folks in the audience to approach the committee with any questions or comments or... No? Okay, none being heard. We have 31 minutes to sit here. Or I would entertain a motion to adjourn.
So moved.
When is the next meeting?
I don't know. When is the next meeting? 3 months from now.
In August 2021.
August 21. Okay. All right. All in favor of adjourning? Opposed? We stand adjourned.